We'd like to open the discussion out to the audience. I believe there is a question on the iPad.
Yes,
Matthew,
there is a question on the iPad. Why has 10 centimeters beyond the LSA been used as a cutoff for emergency frozen elephant trunk?
I'm not really sure. Do any of you have an opinion, Ness?
Yeah, I think this relates to one of the recommendations, the European guidelines in favor of a liberal use of a frozen elephant trunk in case of non-A, non-B. It means that you have it's basically an attribute or tribute to the goal or entry tear oriented procedure, treatment procedure. And the elephant trunk can take care of that entry tear, and in very rare cases, only if the arch is not really involved, a TEVAR procedure would be adequate. But I think it was meant in the context of a non-A, non-B with participation of the arch region, so an elephant trunk in a semi-elective fashion would be the appropriate recommended approach.
I think one thing that's important when you're considering extending to a frozen elephant trunk or maybe an AMDS device for certain is that if you have a tear that's beyond 10 centimeters, especially in an AMDS, you probably should use a guide wire under ultrasound guidance. Otherwise, you could end up in that false lumen without knowing it. Yeah. I had a question for Professor about the type B risk score. It dawns on me it could be a benefit to help determine what's the best treatment for those patients. Type A's, we either do surgery or we don't. But type B's, should we do surgery, endovascular? Maybe the score could help out in that way?
Well, the score from IRAD was developed at a time when there was very few TEVAR interventions. Mm-hmm. So on retrospect, it could be helpful, but we don't have prospective data on that because the patients that were used, the patient data used at the time for generating this type B score were basically all candidates for medical management, palliation, and in some cases for open surgery. Mm-hmm. But you're right, it could be used probably as an indicative of patients that benefit from an intervention. And the intervention these days would rather be an endovascular than an open surgical in the type B scenario.
For sure. Yeah, I mean, the idea that we should do more TEVARs essentially for uncomplicated type Bs, probably there's subgroups of patients that would benefit and subgroups that wouldn't. So that would be important to tease out.
Any more questions? Oh, I think there was there's two. Go on, George.
George Chrysopoulos from Oxford. Given the new recommendations that they allow for more liberal use of FET and more extensive surgery to the arch, do you think the aortic dissection should be performed only by trained and with enough experience aortic surgeons? It's a provocative question, sorry.
I've got an interesting sort of comment to that. And when I moved from Washington University to Baylor and Texas Heart Institute, I joined Joe Caselli, and I was doing FETs on my dissections, and I said, why don't you do any FETs? He said, I never had a problem until I started doing FETs on dissections. And so, I mean, I think, and he's done probably more TEVARs than anybody on the planet outside of China. So, you know, people have, I don't think it's definitive that we do FETs. Do you do them in every case? I don't know. Some people do.
Treating the arch and doing a frozen elephant trunk, but does every surgeon, at least in the UK, who is a call tonight, is he capable of doing it?
Certainly we shouldn't encourage it in a guidelines, knowing that most of the dissections, well, in the UK, are performed by people who do less than 4 a year. And so sort of forcing them through a guidelines to consider doing something they rarely do is probably not a good idea. Because, you know, we've got experienced centers like yours where if the patient comes back and needs an arch replacement, you know, we can probably reliably perform that down the road.
Just to add to this, I mean, the strong recommendation, of course, to send the patient to repair and replacement of the ascending and the hemi-arch in the majority of cases with a 1A recommendation. If a patient shows further major communications in the distal arch or in the proximal descending aorta in a type A scenario, of course, an elephant trunk needs to be seriously considered if there is the expertise. And we are moving towards aortic centers that have the expertise, both from a surgical point of view as well as from an endovascular point of view. But this is not happening yet. I mean, we saw that more than 50% of type A patients are not even treated in this country. So, I mean, this is an indication towards future activities, and it's not happening yet.
I think we have time for one more question, yes?
Thanks for the presentation. Walid Al-Mahdi from Leeds. I just wondered, no mention in the type B and non-A and B treatment other than frozen elephant trunk or endovascular, but not the hybrid. Because at the end in type B, you need a landing zone. If a debranching and TEVAR happen, that would eliminate the risk of total circulatory arrest, spinal cord ischemia, and at the same time, you have a better manipulation with endovascular as an endovascular procedure regarding the guide wire and placing of the stent, so on. So I think that's an option because we had experience in 2 patients before in the same situation, particularly in a softish indication like uncontrolled hypertension. The patient had fenestration, pressure better, and then he had a hybrid debranching followed by TEVAR on the same setting. So that option, I think, has a lower risk, and it's not mentioned much. I'm not sure what you think, Christopher, about it as well.
Well, the example that I showed, the pictorial example that I showed in the 2 papers, 2 slides on non-A, non-Bs was exactly such a case with a debranching and then a TEVAR with a side branch to take care of the problem in a so-called sequential or staged way, which is the way we went along in the past. You know that when we worked together. So that was our standard go-to procedure. And now with the FET more liberally used, I think it may move towards the FET instead of a separate TEVAR procedure in the future. The story hasn't been completely resolved yet. We are still struggling to get the patients in time as everybody else, but we have at least 2 options.
Any final comments?
You know, I think predicting risk is important in assessing maybe how your institution's doing. I think predicting risk for an elective procedure obviously is important to weigh. I'm not so sure I'm sold on predicting risk in a clinical emergency is helpful in management of that particular patient. It's more epidemiologic than individualized maybe.
Thank you. Thank you very much. I think that brings this session to a conclusion. Thank you, everybody. There is now, and I'd like to thank all of our speakers.